Alcoholism is the second most common cause of cirrhosis in the US. The 5-year survival among all cirrhotic patients is 70%, but it's only 30% in drinkers who have decompensated cirrhosis. In contrast, the prognosis improves with abstinence. After alcohol cessation, the 5-year survival of patients with compensated and decompensated cirrhosis can climb as high as 90 and 60% respectively. In one population-based study, smoking more than 10 grams of tobacco per day nearly quadrupled the risk of alcoholic cirrhosis and more than double the risk of other types of cirrhosis in women. Many drugs depend on the liver for metabolism, or they require albumin, which is synthesized by the liver, for their pharmacokinetics and their distribution. Cirrhosis alters these processes, making reduced doses, or in some cases, avoidance necessary. Some recommendations are to reduce the medication dose in consultation with a doctor. Opioid analgesics, anxiolytics and sedatives can cause or can worsen hepatic encephalopathy symptoms, and they should be used cautiously. Non-steroidal anti-inflammatory drugs can more easily cause renal failure and gastrointestinal bleeding in patients with cirrhosis, and these should be avoided. Anti-cancer and immunomodulating drugs. Lower doses for these would be recommended. Antimicrobials should be avoided. Proton pump inhibitors and histamine blockers can lead to serious infections. The antidepressants can have their half-life and their clearance altered, and cardiovascular drugs might need to be adjusted. Coffee consumption has been associated with a lower incidence of cirrhosis in several observational studies. In one study, 4 or more cups of coffee per day reduced the risk of alcoholic cirrhosis by 80% when compared to non-coffee drinkers. For 1 to 3 cups, the associated protection was 40%. The same study found non-alcoholic cirrhosis, 4 cups or more per day, conferred a 30% reduced risk of cirrhosis. Coffee may reduce the risk of fibrosis by lowering the blood levels of growth factors that are associated with liver damage and fibrosis. Coffee consumption has been associated with a reduced risk of liver cancer in several European and Japanese studies, especially among heavy drinkers. Consumption of over 3 cups of coffee per day might reduce hepatocellular carcinoma risk by an average of 55%. This was seen in over 12 observational studies. Some benefits of coffee might be due to its antioxidant content. There's no definitive indication of exactly which coffee compounds are responsible for its health benefits. However, the chlorogenic acids, a member of the group of antioxidant compounds known as polyphenols, have been shown in animal models to reduce liver inflammation and fibrosis. Liver disease in general, and cirrhosis especially, increases the likelihood of malnutrition, and this is not surprising given the vital role of the liver for maintaining nutrient levels and energy balance. The European Society for Clinical Nutrition and Metabolism, the International Society for Hepatic Encephalopathy, and Nitrogen Metabolism Consensus, and other groups have developed recommendations for avoiding malnutrition in individuals with cirrhosis or hepatic encephalopathy. Patients should strive for an energy intake of 35 to 40 kilocalories per kg body weight per day. Moderate gradual weight loss is indicated for many individuals with non-alcoholic fatty liver disease and NASH. Dietary fructose has been associated with metabolic syndrome and diabetes, 2 conditions that are associated with non-alcoholic fatty liver disease and NASH. Restriction of dietary protein is not recommended unless it's not tolerated due to the hepatic encephalopathy. The diet should include 1.2 to 1.5 grams per kg per day of whole protein to avoid muscle wasting. Patients with both alcoholic and non-alcoholic related cirrhosis might be deficient in water-soluble vitamins, especially thiamine, and supplementation is warranted in patients with decompensated cirrhosis. B12 and folate deficiencies have been reported in HBV and HCV infection. The folate deficiency was present in one study of obese patients with non-alcoholic fatty liver disease. Low folate concentrations were associated with elevated levels of vasculotoxic compound homocysteine in cirrhosis patients in an observational study. Patients with cholestatic liver disease might have reduced absorption of the fat-soluble vitamins A, D, E, and K. Vitamin A deficiency is also a common problem in a hepatitis C infection, and vitamin K might be useful in the treatment of bone loss in patients with cirrhosis and chronic liver disease. Tissue zinc levels are decreased in patients with cirrhosis and hepatic encephalopathy, though trials of zinc supplementation have had conflicting results. Hepatic osteodystrophy, a common consequence of cirrhosis, can lead to a calcium-magnesium imbalance. One study found that untreated hepatitis C patients presented with lower levels of plasma and red blood cell zinc and selenium than the healthy control subjects. Viral hepatitis B and C is the leading risk for developing cirrhosis and liver failure. Several nutrients have been studied in human trials for their effects for minimizing the risks and improving the outcomes of hepatitis B viral infection, either alone or as adjuncts to the antiviral drugs. These include green tea extract, selenium, coffee, chlorogenic acid, zinc, whey protein, astragalus, schisandra, and milk thistle. The nutrients S-adenosylmethionine, or SAMe, N-acetylcysteine, or NAC, alpha-lipoic acid, whey protein, milk thistle, licorice, schisandra, vitamin D, coffee, zinc, curcumin, and L-carnitine have all been investigated in human trials as potential adjuncts to hepatitis C treatment. In the United States and the developing world, non-alcoholic fatty liver disease and NASH together are the third most common cause of cirrhosis. Vitamin E, omega-3 fatty acids, and N-acetylcysteine plus metformin have each been studied as possible adjuncts to the treatment of non-alcoholic fatty liver disease and NASH. High iron stores are a risk factor for the development of liver disease, and patients with hereditary hematochromatosis are at an increased risk of cirrhosis. Nutrients that have been investigated in human clinical trials for their ability to reduce iron load include pectin, milk thistle, and green tea. Milk thistle and its principal flavonoid mixture, silmarin, have shown remarkable hepatoprotective and antioxidant effects against several types of liver damage, including chemical, viral, inflammatory, and poisoning, in lab, rodent, and human settings. They've been investigated for a number of chronic liver conditions that precede cirrhosis, including viral hepatitis, alcoholic liver disease, and non-alcoholic fatty liver disease. Studies in cirrhotic patients have shown mixed results. In a study of patients with alcoholic and non-alcoholic cirrhosis, the 4-year survival rate was higher in the patients on the silmarin, who had 140 milligrams 3 times per day, compared to the control subjects. It was 58% versus 39%. A similar study, however, failed to show any survival benefit at 6 years in patients who were taking 450 milligrams of silmarin per day. It's important to note that all the patients in the second study had alcoholic cirrhosis, and many significantly reduced their alcohol intake over the course of the study, possibly obscuring any effect of the silmarin. In patients with alcoholic cirrhosis, the silmarin reduced the markers of oxidative damage and it improved the antioxidant status. Branched-chain amino acids, leucine, isoleucine, and valine, are nutritionally essential amino acids, and they're not metabolized into energy in the liver. They're taken up by skeletal muscle, where they serve multiple purposes. The breakdown products of the branched-chain amino acids can be used to form amino acid glutamate, which can scavenge toxic ammonia in the skeletal muscle and convert it into glutamine. A systematic review of 8 trials with 382 cirrhosis patients on the use of branched-chain amino acids for the symptoms of hepatic encephalopathy demonstrated a clear benefit for reducing the manifestations of the disease in the patients with both minimal and overt forms of encephalopathy. The effect was independent of the cause of cirrhosis, be it alcoholic or viral, and the average dose was 0.25 grams per kg per day. Other authors believe the effect of the branched-chain amino acids is entirely a result of their leucine content, and that while branched-chain amino acids may eventually be proven to have nutritional benefits for cirrhosis patients, including regeneration of liver cells, they're not effective for hepatic encephalopathy. For more on cirrhosis treatment, or herbs, supplements, and natural treatment plans, check out my website.